I'm Jessica McDougall, and I'm a kidney transplant coordinator with the London Health Sciences Centre here in London, Ontario. A major part of my job is processing referrals to our program and doing my best to help people get on the transplant waiting list. There are a number of qualifying factors to be eligible for a kidney transplant with our program. One of those factors is that a patient must have a suitable BMI. Let me tell you the outline of my presentation today. First, I'm going to talk about the problem I see in using BMI to assess some of our patients. Second, I'll provide a rationale for my intervention. Third, I'll let you know my research question. Fourth, I'll let you know the results of a critical appraisal of the literature I recently conducted. Fifth, I'll tell you some details about an organizational intervention I propose for changing clinical practice in my hospital. And finally, I'll return to the question to conclude my presentation. Accepted clinical practice guidelines state that patients are at an overall higher risk for kidney transplantation if they carry excess weight. As a result, weight loss is a requirement for obese patients facing kidney failure who wish to be considered for kidney transplant. The London, Ontario Kidney Transplant Program does not accept referrals for patients with a body mass index greater than 40. Quite often, even patients with a BMI greater than 33 to 35 are asked to lose weight prior to being approved for kidney transplant for the kidney transplant waiting list. For years, physicians and nurses with my program have informally questioned the reliability of body mass index for assessing patient fitness for kidney transplant. While some clinicians stand by the BMI limit imposed by our program's policies, others recognize the variability in outcomes for both high and normal BMI patients. Indeed, patients who are rejected from our program's waiting list were often accepted by other programs in other cities, some with a reputation for accepting high-risk patients. Some of my colleagues question why we don't transplant these patients when other programs do. Does the evidence support other programs' decisions, or does the evidence support our program's decision? Answering these questions has been the motivation for my presentation today. My critical appraisal compared and contrasted 5 studies discussing BMI as a screening tool for patients seeking kidney transplant. The appraisal first structured results from a literature review of PubMed and CINAHL research databases. Next, the appraisal selected the 5 most relevant, highest impact studies. All of the 5 studies were either retrospective or prospective cohort studies. Finally, the critical appraisal skills program checklist was used for critically appraising cohort studies. The results were mixed. 3 of the studies concluded that patients with an elevated BMI at the time of kidney transplantation did not have an increased risk of negative outcomes, while 2 of the studies concluded that an elevated BMI was a significant risk factor for increased negative clinical outcomes. One paper I appraised went further in concluding that waist circumference measurement is actually a superior tool to BMI in predicting negative clinical outcomes. Waist circumference is an alternative to BMI that my program has considered for the past few years. Building on that, the intervention I propose is one that responds to the current evidence around using BMI and using waist circumference as an assessment tool for patients requiring kidney transplant. My intervention proposes assessing patients using waist circumference instead of BMI. I believe the evidence shows that this will improve access to kidney transplantation in London and elsewhere. However, a clinical intervention is difficult in transplant medicine where patients cannot be randomized into a no transplant control group due to the severity of their disease. Therefore, my intervention is an organizational policy change intervention, one that uses stage theory to implement this new policy. Specifically, this organizational change intervention involves disseminating information about the new policy, which could be done through best practice guidelines, implementing the new policy, which would be done at the hospital, outpatient clinic, and satellite clinic levels, and stabilizing practice around the new policy, which would include buy-in from the provincial and federal health services. In conclusion, This research responds to current evidence that BMI is not necessarily a sufficient marker for patient suitability for transplant. My original questions asked whether the evidence supports other programs' decisions to transplant patients with higher BMIs, or whether the evidence supports our program's decisions. What I found was that the evidence supported the other programs, and that in order to give the most patients the best chance for transplant, we need to create organizational change. In order to ensure change, my intervention will seek change at the organizational level to support waist circumference measurement. Thank you so much.